Hello and welcome to The Print. I am Ruchi Bhattar, and in a historic first, the Supreme Court of India permitted the implementation of the first case of passive euthanasia under judicial supervision in India. Today, it allowed the withdrawal of life support for a 32-year-old man who has remained in an irreversible permanent vegetative state for the past 13 years after falling from a building, effectively implementing the legal framework for passive euthanasia for the first time in India.
Hello everyone, I am Sneha Richarya and we are going to discuss the legal and medical implications of the Supreme Court order. For this, we are joined by Senior Advocate Jaina Kothari and Dr. Rajat Agrawal, who is a Director in the Department of Critical Care at Fortis Escorts Heart Institute in New Delhi. Thank you so much for joining. So my first question is directed to Dr. Rajat. Sir, if you could explain what exactly is passive euthanasia in the medical terms, and also what this verdict really means for end-of-life care in India.
So, thank you. It's a very pertinent question and a very burning question, especially in the medical field nowadays. So, basically, euthanasia is a practice of ending patients, person's suffering and pain within the legal framework. That is what the euthanasia means. Now, obviously, the euthanasia has two components: passive euthanasia, which is being practiced in India and majority of the countries, and one is the active euthanasia. That means you actively intervene in terms of ending a patient's life. It's very controversial. Active euthanasia is very controversial, but passive euthanasia is the one which is being practiced, and it has all the legal backing behind it. So that is what the passive euthanasia is, and that is what has been approved by the Supreme Court of India. For the end of life care, as a society, of an intensivist, I'm an intensivist, so Indian Society of Critical Care Medicine has been advocating very strongly for last 15 years or so about making certain rules and regulations in the Indian Constitution for the end of life care. The judgment which came today for this person is a step in right direction.
All right. Thank you so much, sir, for giving us the medical aspect of it. Coming to the legal side, Advocate Kothari, could you please walk us through the legal journey of the Supreme Court and the passive euthanasia, the Aruna Schwanbag and the common cause judgment?
Sure, thanks. So, the whole conversation on legalizing passive euthanasia initially started with the famous Aruna Schwanbag case. The Aruna Schwanbag case was taken to the Supreme Court by a journalist, asking for some passive euthanasia to be provided for Aruna Schwanbag, who was in a permanent vegetative state. That was one of the first cases in India. In that case, though the Supreme Court did not allow euthanasia for her on the ground that she was being looked after very well by the staff, the court laid down certain guidelines on passive euthanasia, saying that in what conditions passive euthanasia can be permitted, if at all, and certainly not active euthanasia. Thereafter, we had the common cause case. In the common cause case, which was another set of that went to the Supreme Court, in 2018, the Supreme Court laid down elaborate guidelines. And most importantly, the court laid down that along with the right to life, the right to life includes the right to die with dignity. And what are the conditions in which passive euthanasia can be carried out? The court gave a distinction between what is active euthanasia and passive euthanasia. Passive euthanasia is where life support, prolonged life support can be stopped. So the doctors can take those steps not to continue. It's not to continue for the life support, but with in what situation, what are the guidelines with court directions, and also lay down advanced directives in what situations a living will could be made by persons. Now, while we did have those guidelines were not really being operationalized. I'm sure even we have the medical expert with us. There were many hurdles in operationalizing those guidelines. So I think in this case today, the judgment that has come, the court has tweaked those guidelines. The court has today, in the Rana case, again improved those guidelines and elaborated how those guidelines can be applied, when passive euthanasia can be applied. So, for example, the court has said that the decision for passive euthanasia is to be taken in the best interest of the patient. How do you decide the best interest? Best interest can be decided both by the family and also by the medical team. And even the expansion of the definition of passive euthanasia has been given. So, for example, in this case, see, I mean, it's in practical terms, I'm sure family members and doctors both find it very difficult to decide when to carry out passive euthanasia. For example, can you stop life support care? And here the court said that in this case, the patient was on all kinds of life support, nutrition, food, all of that was by, medical intervention. And so the court said that that also is medical treatment. And if a decision to stop this medical treatment is to be made, that can be made in the patient's interest, and that has to be done by both the family and the medical team, and laid down guidelines on how that can be done, so that in the patient's best interest, such a decision can be actually operationalized.
Dr. Rajat, I want to actually go back to what you've said earlier. You said that there was a need. I mean, it was a long in demand, the guidelines. And I want to ask you, what caused the need for well-specified guidelines in this? I mean, what led to that demand? And also, after you answer that question, if you could also explain, in cases like when patients are in a persistent vegetative state, so how do doctors actually determine that recovery is no longer possible and now there's a need to withdraw life support?
Yeah, so I think we have seen now with the life expectancy increasing and people are living longer. So we have come as a certain level that we are able to cure and treat certain diseases to a reasonable degree. But the problem comes in chronic diseases and in certain unfortunate cases like person having head injury, person going into coma because of his extensive brain damage. Now for these cases, it becomes a challenge for the medical professional as well as for the family members. For the family members, the financial drainage, the emotional, which is their drainage out of the taking care for a long period of time. For the doctors, the frustration that you're not able to treat your patients and you're just ending and there's nothing beyond that. Now, for these cases, it was a long felt need that certain guidelines which you have like in US and European countries, that if it is as the madam esteemed lawyer pointed out, there was esteemed that if we have certain things from the law that yes, we can terminate the active going for the passive euthanasia and do something well so that the patient doesn't suffer. And the important thing, what we see and what we discuss with the family members is, supposing if the patient was able to take that decision, if he was alive and conscious, would he have liked to continue in this circumstances or not? Now, that's a very important. Would the patient like to be bedridden? Would the patient like to be unconscious? Would he like to continue like that on artificial life support systems? So this was a long felt need that yes, we need to have certain guidelines and not. And yes, the doctors were very, afraid that if they do something drastic, then was always a problem of litigations. Who they might end up in certain legal tangles, which we are very, as a doctors, medical professionals, we are very much afraid of. So the most common thing was just do nothing and just let it be. So this becomes a problem now. As after last Supreme Court order of 2018, they defined as the persistent vegetative state, and after that the guidelines were laid down by the Supreme Court. And I think recently also one of the draft came by the Union Ministry from the Family and Welfare. So for these cases, now the things are in a way that yes, first one has to clinically document that yes, it's an end of life care, or this futility of continuing the support. Secondly, a board is being constituted by the hospital, which involves a neurologist, which involves an intensivist, that is an ICU physician, and one or two other specialties which are not directly involved in the case. Once that board concludes that yes, this patient is meeting the criteria legally, medically, to go for the end of life support, the recommendations are being sent to the district collector. So they form a second medical board, and then whether the independent board, and then whether they conclude with these current findings or not. And then once everybody, and obviously the family's consent in next kith of kin is the first and foremost one, and only then these boards are being constituted, and then the decision is being taken for terminating the life support systems. So that's how currently the systems are being doing.
Okay. Thank you so much, sir, for telling us the medical side of it. Coming to the legal edge of the sword, this is the first case of implementation of the Supreme Court's framework. Ma'am Kothari, please explain us how big is this verdict in terms of the fundamental right to die with dignity? And secondly, also please elaborate how do we balance the two competing principles of the duty to preserve one's life and the individual's right to right to die with dignity and autonomy.
Yeah. No, I think it is actually quite an important, moment, because the Supreme Court has really laid down and operationalized the right to die with dignity, and this becomes very important because we are seeing constantly families, caregivers struggle with this, right? You want to enable someone to live and die with dignity, but those steps to take to ensure that the person's end of life is done with dignity is has been very, very difficult. So I think this decision, which lays down and actually simplifies it in many ways simplifies passive euthanasia guidelines of common cause. In fact, the court laid down that even where a person is not in the hospital but is at home, and caregivers want to say that this decision should be taken, they can do it with the treating doctors and physicians. Medical board decision can be taken, and thereafter you can immediately approach the High Court, and within a fixed timeline, this can be carried out, and in the patient's best interest. So one is, it has clarified those previous guidelines to make it actually easy to operate. But at the same time, it doesn't mean that it allows any decision to be taken for passive euthanasia. So the court has actually given many safeguards and guardrails. One is, for the medical team and for caregivers, the guideline has to be best interest. Now, best interest also, the court has laid down, how do you decide? The court has said you look at both sides. What is the situation of the patient? What is required to be done? What are the outcomes for improvement? You look at both sides, and then you take best interest. If the patient has already expressed his or her wish, that also to be taken into account. And then finally, with the family, with the medical board and the experts, then the decision is to be taken. And in fact, the court has said that where there are different medical opinions, that also can be reviewed. And finally, that this cannot be taken to kind of open a gateway for anyone to seek passive euthanasia, So it's not as if even these decisions can be taken unilaterally by caregivers or the doctors. It ultimately, you have to refer it to a medical board and then go to the court as well. So there are guardrails, and I think this will only enable to quicken the process where the situation is really dire. So I think it's an important decision for passive euthanasia. Hopefully, it will streamline the process, make it less difficult for both family members and for the medical teams.
Thank you.
Yeah. Thank you for that important legal observation. I back to come back. I want to come back to you, Dr. Rajat, and ask you about, under the current guidelines, what medical safeguards are actually followed before such a decision is made to withdraw life-sustaining treatment, and also what is the current medical framework for passive euthanasia in practice, especially when it comes to the role of medical boards, hospitals, and family consent.
So, first and foremost is obviously the clinical aspects of the case. That is that the extensive, thorough clinical examination by a team of doctors that yes, this person is fitting into the category of being allowed passive euthanasia. For that, we need to do certain complex imaging, like we need to go for, say, CT scans, MRI, EEG, electroencephalogram of the brain to see the brain activity, other parameters, systemic examination, etc., etc. So these are the medical aspects of that. Then the primary care doctor who is in charge of that patient discusses in detail, preferably along with if you have facilities of a clinical psychologist or a social worker, that yes, the patient is unlikely to survive or to have a meaningful life, even if we continue the medical support as of now. The exact definitions, unfortunately, are not there. For that, probably we still, as a society and as a are still evolving. So that are still not there. But yes, once these things are discussed and patient's family, next kin agree that yes, that is there, then as I discussed just now, that we constitute a board with various team of specialists who decide whether yes, this patient fits into the category of passive euthanasia or not. Then it goes to the district collector, who forms a separate board, and then it decides whether, and then it goes to the High Court for the final decision that yes, this person comes into the category of passive euthanasia or not. There are certain safeguards, but the last draft which was there from the Union Ministry of Family Welfare, the Indian Medical Association was not too happy with that, because there was not very legal clarity on what comes under passive euthanasia and what not comes under that. Also, there's always, as I mentioned earlier, a question of litigation. Now, supposing the patient has, say, wife, brother, and sister, for example, and they give the consent, and the process takes, say, 2 weeks. After that, the passive euthanasia is done. Say 1 month down the line, the patient's brother or maybe a related distant cousin comes into the picture and says, no, what was done was wrong. They were in collusion with the treating doctors, and my relative should not have undergone this procedure. So all these things are still very, are not very crystal clear. It's still very fluid situation. So the decision of passive euthanasia is still, unfortunately, not that they're being given more. It should be given more rather, but that is still being withheld because of various reasons. So I think, but as I mentioned, it's a very welcoming step, at least from what was, say, as Madam has mentioned about Aruna Shanbag case. So I had seen that person, and in KEM hospital, that lady who was being monitored and being cared for, and the nurses who are that hospital, I mean, they did for 18 years, which I think I recall that they managed her, and if there was not an inch of bed sore, there was no problem, no infection, and they just took care of wonderfully. And even after so I think such cases are there in the medical fraternity, and we need to have more clarity and more. I think probably the laws may be better before we can offer these type of alternatives to the patient's family.
Ruchi, I just have a quick follow up on what Dr. Rajat had earlier said. So you mentioned the draft norms that came up around I think September 2024, and I was reading that it had at that time sparked some concerns among doctors. So if you could quickly explain our viewers what was the concern around those drafts that came around that time.
I think what I just mentioned, the thing was that the definition of which patient's exact category comes under the category for these for this medical euthanasia and passive euthanasia and persistent vegetative state. So those things are still not very much clear. They have given certain guidelines, but still that if you read the draft, it is not 100% clear that what comes and what not. So probably that is the thing. Secondly, the procedure documentation of that. It involves a lot of documentary part, certain, making a one board, then going to the district collector's office, making another board, and then coming back. Obviously, it takes a lot of time. So that is the second part. It's very time consuming and sometimes frustrating for the patient's family members as well. The third part is, as I mentioned, about the litigation aspects. They are still not clear that, yes, if somebody is suing the healthcare professionals, what are the legal safeguards to protect that? So I think those need to be still laid down more with clarity before the medical professionals and medical society as a whole can take it up in more readily.
Thank you, sir. Thank you for explaining the need for a legislation right here. Ma'am, do you think India now needs a specific legislation on end-of-life decisions, and instead of relying on Supreme Court guidelines? And how do you think we can move forward in terms of statutory regulations?
Yeah, no, I definitely think we need a legislation. In fact, even in this judgment, the Supreme Court has said that these are just temporary guidelines and there needs to be a proper legislative framework. So definitely you need a statute, because then the statute will, as Dr. Rajat said, the statute will elaborate what all falls under passive euthanasia, and then what are the exact steps to be taken, though the Supreme Court has laid down guidelines. See, ultimately, the Supreme Court lays down guidelines in many instances where there's a vacuum. For sexual harassment prevention at the workplace, we had a guideline. We had the guidelines. And then we got a law, I think maybe 13 years later, and then the law is actually enforceable in every workplace. So similarly, though these guidelines are extremely important and clarificatory, but you do need legislation so that the exact definition, the exact steps, what to do where things are not followed, to have redressal procedures, all of that could be actually mandated.
Okay. Thank you, ma'am, for explaining the need for guidelines. My final question to Dr. Rajat would be, so you mentioned the practice across the world briefly, I think, during your conversation. So I want to understand how other countries across the world handle euthanasia. I think some of them even allow active euthanasia. So in which part of the world is it legal, and how do their medical guidelines compare with the Indian approach?
I think certain European countries, to my knowledge, like Holland, Belgium, Canada, are very active in allowing passive euthanasia and to certain extent active euthanasia. But these laws, as Madam has also pointed out, are also how the our societies and our culture are being evolved. So, those though they have different cultural values, they have different setups. The laws are based as per their systems, their countries. US, for example, and to certain extent United Kingdom as well, only allow passive euthanasia. I agree. We are started we have started, and we are and it is we are still a lot of catching up to do. But yes, I think we are going to go and form definitive guidelines and framework more in a better way, and there's no legal hurdles and no confusion amongst the citizens of India. So that is my take on that.
All right. Thank you so much for joining us today, Dr. Rajat and Advocate Kothari. It was a pleasure. And thank you so much for taking out the time. Thank you, Sneha, for conducting this very smoothly with me. If you have nothing to add, we'll end this here. Thank you so much to our viewers for watching The Print. For more from The Print, subscribe to The Print.